Thank you, Chairwoman Miller-Meeks. At the outset of today's hearing, I'd like to set the scene a bit by describing the situation in which veterans and the VA currently find themselves. First, veterans across the country are losing access to VA health care due to numerous actions taken by the Trump administration. Why is this happening? With each passing day, VA is becoming a less and less desirable place to work. Upon taking office, President Trump ordered a government-wide hiring freeze. The haphazard implementation at VA meant that essential occupations initially were not exempted from the freeze. Job offers for key employees who were already in the onboarding process were rescinded, then reinstated, a flip-flopping that led many would-be hires to run the other way. Less than a month after that, VA terminated nearly 2,400 probationary employees. While some have since been rehired, they may be terminated again after pending lawsuits have resolved. Many opted not to return after being offered their jobs back. Then, as a result of the Trump administration's returning to office policy, tens of thousands of VA employees who had been hired into fully remote positions were directed to report to offices that were ill-equipped and ill-suited to accommodate them, with little consideration for the effect it would have on their productivity or the quality of care delivery. We heard a week ago that while VA is no longer planning to pursue a large-scale reduction in force, or RIF, it still anticipates losing nearly 30,000 employees by September 30th. That's about 6% of VA's overall workforce. This is happening through DRP, the Deferred Resignation Buyout Program, and VERA, the Voluntary Early Retirement Authority, as well as employees choosing to resign or retire without any incentives. As this chart shows, behind me here, as of May 31st, 2025, nearly 22,000 employees had separated from the Veterans Health Administration. While about half have been replaced as a whole, VHA has lost 10,310 more employees than it had hired so far this fiscal year. The Secretary has repeatedly claimed that veterans will not lose access to health care as a result of the department's ongoing restructuring process. Maybe you're thinking that these losses are mostly non-essential occupations at VHA, but that is just simply not true. Losses of essential frontline employees are occurring at VA medical facilities nationwide. The second chart shows VHA is currently operating at a loss of nearly 3,000 mission-critical employees since the start of this fiscal year. This is after making significant gains in the overall number of frontline employees during the same period last fiscal year. Those new hires were helping VA deliver record numbers of appointments and serve the influx of new enrollees that are coming into VA as a result of the PACT Act. Where are the losses of essential employees most significant? Custodial workers, food service workers, nurses, physicians, social workers, employees that VA medical facilities simply cannot do without. At the CBOC that serves my constituents in Ventura, California, 7 out of 12 mental health providers have left. This is driving up wait times for mental health appointments. As of Friday, the new patient wait time for a mental health appointment was 101 days. Now, maybe you're thinking to yourself, those veterans are eligible for community care. And while that is true, they need VA staff to coordinate their care in the community. And as this chart refers, 2 shows that we are down more than 1,147 medical support assistants nationwide since the start of the fiscal year. Those are the staff who help veterans find community providers and schedule their appointments. It doesn't matter that so-called mission-critical VHA staff were not eligible for the DRP and VERA separation incentives. They are leaving anyway because VA has become a toxic, unpredictable, and hostile place to work. We are kidding ourselves if we think no RIF is the end of it and that the loss of employees will stop at 30,000 folks. These losses will continue to grow. As long as VA's workforce continues to suffer, all aspects of VA care, including community care, will suffer. Second, on July 4th, President Trump signed the One Big Beautiful Betrayal Bill into law. By most analysis, this law and its $1 trillion cut to Medicaid will have a wide-ranging impact on the healthcare landscape in the United States. Researchers at the University of North Carolina have identified 338 rural hospitals that are already at risk for closure. Future loss of Medicaid coverage will elevate the risk of financial distress for hospitals, long-term care facilities, and other providers, further reducing veterans' access to care. We cannot have a conversation about specialty care in the community without acknowledging both the strain that is currently being placed on VA's healthcare system and the strain that is about to be placed on non-VA providers. We should be shoring up VA care and making sure that there is capacity in the community when veterans need specialty care in the community. Instead, under this administration, we are seeing a chaotic approach to delivering veterans health care that undercuts VA's internal capacity, shifts more and more care to the community, and leaves veterans and VA employees in the lurch. Insisting that those actions will not impact veterans' health care does not make it so. And ignoring the unforeseen consequences of this administration's actions will not make them go away. As I have always acknowledged, VA will always need to offer some level of community care because they can't do it all. However, for many veterans, VA is the right place for them to receive care. They know their provider understands their military service and what it means to have served their country. They know they will receive world-class health care backed up by world-class research. They know they won't have to explain to their VA provider what a presumptive condition is, or their experience with military sexual trauma, or how their service impacted their mental health. We also lack oversight of the care that veterans receive in the community. We know wait times for VA appointments because VA publishes them. Community providers are not required to report their wait times or how long it will actually take a veteran to be seen. We know that VA providers have received training on military cultural competencies, suicide prevention practices, opioid safety, and many others because VA requires them to receive such trainings and report how they have completed them. Community providers are not required to take all of these trainings, and veterans are not informed about whether their community providers have voluntarily taken such trainings. Based on the testimony from our witnesses, I think we can all agree that the administration of VA's community care program needs reform. Unfortunately, we find ourselves convened for an oversight hearing where there are no VA officials present to respond to questions about the barriers and challenges highlighted by our witnesses. I think that does them a disservice, and I would respectfully ask the chairwoman, to invite department witnesses to future oversight hearings so that we can have a more robust discussion about what is working well, what isn't, and how to fix it. And with that, Madam Chair, I yield back.